Professor. Okay, welcome, Professor Jeremy Hess. And okay, so we also have now with us Dr. Nikhil Ranadive. He is the another speaker from US. So let me start with introducing the speakers for today. We have with us Professor Jeremy Hess. He is the Professor of Emergency Medicine, Environmental Health and Occupational Health Sciences and Global Health. He works at the Schools of Medicine and Public Health University of Washington at USA, and is also the Director, Center for Health and Global Environment. Dr. Hess is an emergency medicine physician with additional training in global environmental health. He pursued undergraduate studies at Deep Springs College and Brown University, and his medical residency and public health training at Emory University, supported by Woodruff Fellowship. He joined the faculty of University of Washington in 2015, where he practices emergency medicine at Harborview Medical Center and the University of Washington Medical Center, Montlake campus. He also conducts research, teaches, and is director of University of Washington Center for Health and Global Environment. Dr. Hess served as a senior medical advisor to Climate and Health Program in the National Center for Environmental Health at Centers for Disease Control and Prevention from 2006 to 2015, and received the Presidential Green Go Award during his tenure there. He has been awarded a range of grants from federal funders and from foundations including the Wellcome Trust and the Robert Wood Johnson Foundation. He is an author on the annual Lancet Countdown on Health and Climate Change reports and a senior author on its accompanying US brief. He is a contributor to the Global Burden of Disease project. He has also served as a lead author on the 3rd and the 5th US National Climate Assessments, the Intergovernmental Panel on Climate Change's special report on managing the risk of extreme events and disasters to advance climate change adaptation, and the Health, Wellbeing and Migration chapter of the IPCC 6th Assessment Report. He lives in Seattle with his wife and 2 children, and he pursues drawing, painting, and sculpture in his spare time. So welcome, Professor Jeremy Johnson. Welcome to this seminar. Let me now introduce our second speaker. He is Dr. Nikhil Ranadive. He is the resident physician at the School of Medicine in University of California, San Fresno. He did his MS in University of California, San Francisco, and then MD from Emory University School of Medicine. And he was granted the Resident Research Award from the Department of Emergency Medicine, University of California, San Francisco. He is the resident in the Department of Emergency Medicine at UCSF Fresno. His research focuses on intersection of climate change and public health, and is particularly interested in understanding sources of vulnerability and designing adaptation measures to both reduce the risk of climate change and help build climate resilient communities. So his interests are in climate change adaptation, vulnerability and adaptation assessment, mitigation health, co-benefits, climate change and health impact, heat health, pre-hospital medicine, emergency medicine, disaster preparedness. And he had a number of publications in international journals, and some of his latest publications are in subjects related to climate change. And welcome, Dr. Nikhil. And it's a pleasure to have you both on this forum. Let me let you all know that we have been joined by over 65 program officers from across India to various districts and states. And all of them, starting March of this year, would be involved in what we know as surveillance of heat-related illnesses. And therefore, it's very important paper that you have published, and would be of immense important for them to understand those nuances that you will bring forward from your findings of your studies, and your recommendations will be highly appreciated in this subject. So with this, I request to both of you, please.
All right, thank you very much, Dr. Shrivastava. Did I say your name correctly?
Yes, that's right.
Okay, good. Thank you. Well, thank you very much for the opportunity to come and speak with you. We are honored, and we are looking forward to telling you a little bit about our work on heat action plans in Ahmedabad, and then also on pre-hospital data collection of temperature and relative humidity data. I am going to begin the talk by providing some context around heat and its health effects, what we know globally and specifically in India, and provide a little bit of information about the heat action plan that we developed in Ahmedabad that then has been used as a model in other parts of India. And then Dr. Ranadive will talk specifically about our study looking at pre-hospital data collection and the use of temperature and relative humidity data in evaluating patients that may have heat-related illness. And then we'll have some time for questions. So I'm going to share my slides. Okay, can you see?
Yes.
Great, thank you so much. Okay, so our goal tonight, well, this morning for you, is to make it so that you are able to describe the health effects of exposure to extreme heat, and to explain how climate change is affecting extreme heat exposure globally and in India. And then for you to relate how Ahmedabad's heat action plan was developed, what its principal components are, and then again, how portable temperature and relative humidity sensors can be used to help assess heat exposure and guide patient care. As we all know, heat can be very dangerous, and there's an interaction between heat and humidity. The higher the temperature, the more dangerous, but the higher the concentration of dissolved water in the air or humidity, the harder it is for us to cool through sweating. And so there's an absolute limit to our thermal comfort and ability to be to operate safely in hot and humid environments. And you can see here the area in red shows where the temperature in degree centigrade crosses a threshold into very dangerous territory, right around 40 degrees centigrade with 40% relative humidity. That feels like a temperature of 55 degrees. But when the humidity is much higher, closer to 95% over here on the right, as you see, a temperature of just 33 to 34 degrees centigrade is very dangerous. And you have a very short period of time where you can operate safely in the heat. We also know that temperature is highly correlated with mortality rates. And this correlation depends on a number of things. This is data from the United States, but the relationships depicted here are the same the world over. And what we see is that cities where it is hotter, this curve is shifted over to the right. So the temperature at which we observe the minimum mortality is higher. We also know that early in the heat season, so in March for you in India, the curve is shifted more to the left. So people are more sensitive to temperature earlier in a heat season than they are later in the heat season. And that's because of acclimatization that occurs physiologically. And also places that are colder relatively, people are less acclimatized. So there's a lower minimum mortality temperature, and risk associated with heat increases at lower temperatures than it does for people who live in hot climates all year round. Oops, sorry. And we see that whenever temperatures increase, that emergency medical service 108 usage increases directly. And we also see increased use of health services, whether it's in the emergency department, clinics, or hospitalizations. That this relationship is very tight with temperature and immediate. Now, many people probably are aware of the classic heat illnesses, heat exhaustion and heat stroke. And these are what most people think of when they think about exposure to extreme heat and the health effects that we see when people become ill after heat exposure. Of course, heat exhaustion is the milder form of the illness. People become faint or dizzy, they sweat quite a bit, they may feel nauseated, they may feel weak and have a rapid, sometimes slightly thready pulse, and they may have muscle cramps. This is an entirely recoverable state. If they rest, if they get to a cool place, they can recover and won't have any problems. But if they don't get to a cooler place and they're not able to recover, then they will be at increased risk of heat stroke. And heat stroke is a more severe illness. Without intervention, the fatality rate for a person with heat stroke is about 25%. With intervention, it can go below 10%, but it's still a very dangerous disease. And the problem in heat stroke is that the body's ability to regulate its own temperature has become overwhelmed by the stress of heat exposure. And so what you see with people with heat stroke is they're no longer sweating because they're no longer able to respond appropriately. Again, they may be nauseated, they may be vomiting, but the most common, and in fact, one of the diagnostic criteria is that their mental status is altered. They're delirious, they're comatose, they may be having seizures, and their core body temperature is elevated, and they need to be rapidly cooled. One of the challenges with heat illness is the diagnoses for these problems is clinical. There are no laboratory tests that are definitive for heat illness, and the physician or the pre-hospital care provider, the medic, has to be thinking about heat illness in order to make the diagnosis and to initiate cooling quickly. We also know from some experience here in the United States and elsewhere that heat illness is really not the only thing we see when we have extreme heat. So during the California heat wave of 2006, we were lucky enough to have some colleagues who studied this event and identified the impacts. And there was quite a substantial increase in healthcare utilization, as explained earlier, with about 16,000 extra emergency department visits during that period, and over about 1,200 excess hospitalizations. What's interesting is the causes. So as you can see here, if you look on this bottom line, heat-related illnesses, heat stroke and heat exhaustion, there was quite a large increase, and the relative risk, or the risk ratio there, was over 10. So a very large increase in heat-related illnesses, as we would expect. But if you look at the actual other impacts, so heart attacks, respiratory and cerebrovascular disease exacerbations of kidney disease, all of these actually saw substantial increases, and the total numbers were much larger. For heat illness, we had about 620 heat-related illnesses during that event, which was a huge increase over, this was hospitalizations. So during the reference period before the event, we had about 400 heat-related illnesses in a 2-week period. During that heat wave period, we had 2,500 ED visits and 619 hospitalizations, and a very large jump in the relative risk ratio. But if you look at these other outcomes, there are very large increases in absolute numbers. So the risk ratio for these different conditions, these chronic disease exacerbations, was relatively small. But in absolute numbers, the jumps were very large. And that's because the population has a lot of chronic disease. And when it was exposed to heat, that heat stressed the cardiovascular system, the renal system, and the respiratory system of these patients, and they came to the hospital and were admitted. So one of the take-home messages about heat exposure is, yes, we see heat stroke and heat exhaustion, and we see a very large spike in them, but it's still actually relatively small compared to the total absolute increase in volume that we see from chronic disease exacerbations that may or may not look like heat stroke and heat-related illness. Also, as you may know, there are a number of different things that either protect you against heat-related illness or increase your risk. And those things have to do with one's ability to thermoregulate properly. So whether you are able to sweat appropriately, and some medications that are particularly medications that are anticholinergic can impair your ability to sweat and to cool off appropriately. Also, having intact thirst mechanisms and responses, intact kidney and cardiovascular function, and then the ability to recognize that one is being exposed to extreme heat and being able to respond appropriately to reduce one's risk, take off clothes, reduce activity, move to a cooler location, etc. And in many cases, this comes down to also being able to make changes. So if you're a day laborer and you are working on a site where you don't have the ability to stop working because you're not allowed, or you don't have access to water to cool down, or for some other reason you can't do the things that you need to do to protect yourself, you'll be at increased risk. And often we see individuals who do not have much in the way of money or social capital struggling in periods of extreme heat, struggling to protect themselves and maintain their health. So in India, I first became involved in heat work after the 2010 heat wave in Ahmedabad. And you can see here in the red dots, this is the temperature during 2010. And that year, Ahmedabad set a record, a temperature of 46.8 during June of 2010. And they had a very serious heat wave. And in previous years, Ahmedabad had also suffered from some earthquakes. And so it was attuned to the potential for disasters and the need to respond appropriately and prepare for disasters. So it asked an international team to come and help think through what it could do to reduce risks related to heat going forward. And I'm going to tell you a little bit about what we found related to heat risks and then what we did about it with our colleagues there. So first we studied that event and we looked at daily death counts in Ahmedabad in 2009 and 2011, which were cooler years. And then we compared that with 2010. And what you can see here is that up through much of the Ahmedabad summer, it was a warmer year in 2010 than previous years, and there was a slightly increased mortality that year compared to other years. And then right around the event, it got dramatically warmer in Ahmedabad, as I mentioned, and we saw a very clear spike in mortality at the same time. And that spike in mortality was immediate, and we did not see a decline in mortality below the trend for that year after the event. This was essentially all excess mortality for that year. And what you can see here, if we look at this running 7-day average mortality for that year compared to other years, that there was a very large spike. And the area under this curve here, all of these deaths were excess. So it was a large number of excess deaths during that relatively short heat wave period. And for that whole year, as I said, there was slightly increased all-cause mortality compared with other years, also presumably because of the heat. Ahmedabad was very concerned because it was warming rapidly. It's a rapidly developing city. Its urban heat island was increasing significantly. And also people were concerned that the climate was changing quickly. And as we can see here, under a high emission scenario, temperatures in South Asia are projected to increase quite significantly. And so people in Ahmedabad were very worried that this was the first of several events that would cause a lot of morbidity and mortality going forward, and wanted us to think through with them how we might develop a protective response. So we worked together to explore what we might do. And we talked about heat action plans. And heat action plans pull together evidence about the relationship between heat exposure and health impacts and identify thresholds for action. They also rely on forecasting, so weather forecasting to pull in information several days in advance about the likely temperature. They create and then issue warnings based on information about the relationships between temperature and the forecast temperature. And so they say, in 5 days, we expect there to be deadly heat and we want people to prepare. And then they outline a number of different interventions that can help reduce risk related to heat. And this may be related to accessing an air-conditioned environment. It may be related to connecting with services that reduce risk for people who are elderly and frail. It may relate to putting water in locations where people need drinking water to cool off during the heat of the day and during intensive outdoor work, etc. Here in Ahmedabad, what we did was create a whole plan where we identified triggers for a warning. And then there was a nodal officer in the mayor's office who was in charge of the entire plan. And they activated the health sector. They also activated labor and transport and power and the schools and the parks. And they had a coordinated response to reduce risk and to create opportunities for people to protect themselves when it got hot. There was also a very rigorous and robust communication campaign that went out through multiple media outlets to make sure that everyone was aware of the heat wave that was coming and what they could do to reduce their risk. We set the thresholds, as I outlined. We went back and looked at the epidemiologic data and identified a temperature threshold where we started to see risk increase. And then we created different levels of warning, yellow, orange, and red, based on levels of danger that we had observed epidemiologically. And then we worked with the Indian Meteorological Department, the IMD, to get forecasts several days out and set up an automated system for communicating those forecasts to the nodal officer, who then made decisions about what kind of activities to trigger under the HAP. We also, as I said, underwent a very comprehensive public awareness and community outreach campaign. And this included media trainings, this included advertisements, this included billboards, engagement with the traffic police, and engagement with lots of community-based organizations. We also put out lots of information about what to do when the temperature was dangerously high, and put that out in multiple languages on multiple locations, so everyone would have a chance to benefit from this messaging. Very importantly, we worked with the medical community in all of the public and private hospitals in Ahmedabad to make sure that the doctors understood the risks associated with heat, how to diagnose patients who may be suffering from heat exhaustion, heat stroke, or having a chronic disease exacerbation because of heat exposure. And worked very closely with the pre-hospital care community, the 108 GVK group, and then also the hospital staff to increase awareness around these conditions. And then we also set up a number of cooling centers, opened up parks, set up drinking water at workstations, and did a comprehensive plan to make the environment cooler and increase opportunities to cool off when people were feeling hot. And when we looked at the HAP's performance several years later, we found that all-cause mortality associated with extreme heat, while still elevated at high temperatures, seemed to have gone down. Now, we can't say for sure that it was the HAP that did this, but we would like to think that it at least was part of the solution to bringing down the mortality rate associated with extreme temperatures over that period of time. We did a lot of work. Our partners and I did a lot of work to tell the story about the HAP and share the information about our activities and our success, and also where we had struggled and what we learned and how we overcame the challenges that we encountered. And as a result, a number of different cities have engaged with this work, particularly through the NDMA, the National Disaster Management Authority. There was promotion of this work and the Ahmedabad HAP model, and implementation in a number of other cities around India. And that is, as I understand, ongoing. I unfortunately have not been able to come back to India during the pandemic, but my understanding is that this work continues, and I look forward to re-engaging as soon as I can and learning about the state of implementation of these activities in India when it's possible for me to come back. So with that, I'm going to thank you on behalf of myself, as well as all the partners that were involved in this work. And I'm going to hand it over to Dr. Ranadive, who's going to tell you about a specific aspect of that work, which was examining a new technology to look at risk for patients who were in the community and may have been exposed to extreme heat, and getting information about the temperature on scene when they're picked up. So thank you very much, and I look forward to your questions, and I look forward to Dr. Ranadive's remarks.
Great. Hi, everyone. My name is Nikhil. Just going to share my screen really quick. So I'll be discussing the study entitled Climate Change Adaptation Pre-Hospital Data Facilitate the Detection of Acute Heat Illness in India. I'll be discussing the study today and some of its key findings. And sorry, just give me 1 second. I'm having some technical issues.
Do you need me to share from here, Nikki?
No, I'm good to go. Okay.
Okay.
Thanks. So this study was led by Dr. Hess at the University of Washington, but involved collaborators from the GVK Emergency Management and Research Institute in Gujarat, the Natural Resources Defense Council in the United States, the Ahmedabad Municipal Corporation in Gujarat, as well as the Indian Institute of Public Health. And so we already know that climate change adversely impacts health in India, and Dr. Hess touched on a lot of that, so I won't get into the details. But our study specifically addressed extreme heat events, which has been shown across multiple studies to have significant adverse impacts on morbidity and mortality across multiple regions in India. And we aim to evaluate tools used in the pre-hospital setting for the detection of acute heat illness, which includes both heat exhaustion and heat stroke, with the overall goal of facilitating the early detection and treatment of acute heat illness, which, as Dr. Hess mentioned, is critical for good outcomes and to reduce mortality. And we specifically looked at 3 tools. Firstly, the use of heat exhaustion and heat stroke case definitions to identify likely acute heat illness cases. Secondly, portable digital temperature and humidity data loggers carried by ambulances to measure on-scene heat exposure. And thirdly, we attempted to identify demographic, health, and environmental risk factors using prevalence data. So this study was conducted between April and June 2016 in Ahmedabad, using a sample of patients who called for ambulance services during that time frame. Participants in the study filled out questionnaires in the field that assessed for heat exposure as well as other relevant risk factors. Pre-hospital providers, that is medics, also measured on-scene heat exposure using portable temperature and humidity data loggers. We then linked this data to temperature and humidity data obtained using more conventional methods, in particular data from the local airport weather station, with the end goal of evaluating the 3 tools that I described previously. This table shows descriptive statistics from our sample. I won't get into too much detail here, but our total sample size was 480 participants. We collected general demographic data, such as sex, age, educational attainment level, prior medical history, the general location of where patients were picked up, clinical characteristics that could be consistent with acute heat illness, as well as meteorological data. So the first thing we did was evaluate the diagnostic accuracy of case definitions to see how well they paired up with the clinical impressions of pre-hospital providers. These were our case definitions for heat exhaustion and heat stroke. They essentially include a series of clinical characteristics consistent with each disease. So for heat exhaustion, this included nausea, vomiting, weakness, muscle cramps, among other symptoms. And then the case definition for heat stroke included having a core temperature of at least 38.5 degrees with some measure of altered mental status. What we found for our case definitions is that they essentially have poor diagnostic accuracy, and at least in this study cannot be used as an early proxy for diagnosis. As shown here, the low sensitivity and positive predictive value. And while this was a disappointing finding, our results for this particular part of the study were consistent with other studies that have attempted to evaluate similar case definitions. We also wanted to know whether portable data loggers more accurately measured heat exposure in comparison to more conventional methods. In particular, we wanted to know whether on-scene heat differed from data obtained from the local airport weather station. And there were two key findings in this part of the study. Firstly, we observed differences in heat exposure at the level of ambulance duty stations. So some ambulance duty stations were hotter than other duty stations. And this map here, all of the orange areas were included in the study. And as you can see, there were differences in mean heat exposure across these different duty stations. Secondly, we found that heat exposure measurements in general were systematically higher from the portable loggers when compared to local airport weather station data. And this figure shows a daily breakdown for each sample in the study. And as you can see, heat measurements from the loggers were across the board systematically higher than from the airport weather station. And this is redemonstrated in this figure here, which shows that among patients with heat exhaustion, the mean heat index as measured by the portable data loggers was about 6.7 degrees higher than the heat index calculated using airport weather station data. So taken together, we think that this suggests that data from local stations may not adequately reflect on-scene heat exposure due to differences in, for example, microclimate conditions. This may have implications for heat action plans and early warning systems that rely on airport weather station data. And while we acknowledge that there may be financial and other limitations and constraints to rolling out this intervention at a national level, we do think there is utility to obtaining higher resolution or more localized exposure data. The last thing we did was attempt to identify risk factors for acute heat illness by using the questionnaires administered by the pre-hospital providers and running a series of logistic regression models. So some of our independent variables included station visibility, which we used as a proxy for air quality, wind speed, and recent physical activity. We found that a recent history of physical exertion substantially lowered the threshold for developing acute heat illness. We also found that access to air conditioning was protective. So this may tell us that we can't rely on temperature alone to determine a patient's risk for developing acute heat illness. For example, if a patient has a history of heavy exertion or lives or works somewhere without an air conditioner, a lower than expected scene temperature or heat index may still result in the development of acute heat illness. Pre-hospital providers should assess for these risk factors, and this may also have implications for heat action planning. Lastly, we found that heat exhaustion cases were significantly associated with decreasing station visibility, which again, we used as a surrogate marker for air quality. This supports prior evidence that poor air quality can modify heat-related morbidity and mortality, which should also be factored into heat action plans and early warning systems. To conclude, the findings from our study suggest that adding additional data to pre-hospital evaluations for acute heat illness can improve diagnostic accuracy. In particular, scene temperature, a history of exertion prior to illness onset, and presence of air conditioning are valuable data points. Lastly, having a standing strategy for collecting additional data regarding activity and scene environment are likely important for the detection of acute heat illness. And that's all I have for you. I was thinking we could open it up for questions now. Unless you have wanted to jump in, Dr. Hess.
Okay, thank you. Thank you, Professor Jeremy and Dr. Nikhil. That was an interesting work that you people have done, and I'm sure it would have benefited my officers who are watching this show as of now. I will quickly try to recap some of the important things that you said for the sake of my officers. And in the meanwhile, I am requesting my officers to place their questions in the chat box or question and answer box, so that if you have any questions, we can request the speakers to address those questions. Meanwhile, I'll try to recap what has been said. Some of the important things that we heard today is Professor Jeremy came across telling us about how we have an importance of identifying heat stroke and how much it is more of a clinical diagnosis, and it's important to check for the cold temperature and how in the paper also there is a mention of how they try to adjust axial temperatures to core temperature. That is something which many of the clinicians tend here to forget, that there is a difference of at least a degree Celsius in the core temperature and the axial temperature. And also about mentioning that how in the US study, that not only the so-called heat-related illness, which we call heat exhaustion and heat stroke, are the only conditions that are accounted for the increase in heat index, but also the exacerbation of other conditions resulting in death. And that is also one of the reasons why, following the work that was done in Ahmedabad, we tried to change our surveillance system from the last year and try to include a parameter of accounting for all cause deaths, not only heat stroke deaths. So this is based on the explanation that we heard from Professor Jeremy, that how the excess of deaths accounted for other chronic diseases also tend to increase when we have an increase in the heat index value. Another thing that he mentioned is about how certain vulnerable groups would be likely to be more impacted, those who are impaired biologically and also socially or behaviorally. So we need to look into the background of the person that we are attending to, as to which background do they come from. His presentation also mentioned about how in Ahmedabad they went about to work on heat action plans, while mostly in India it is the NDMA and their state and district partners who are accountable for development of heat action plans. But all the officers who are presented here have been assigned the responsibility to develop a health sector plan for the heat action plan. And so it is important for them to understand through this presentation how critical is the importance of understanding the temperature threshold, understanding the role of issuing warnings based on temperature threshold, and designing your action plans so that you can take appropriate actions to save lives. Indian Meteorological Department issues heat alerts in forms of heat wave for the next 5 days, and which is based on the information available with them broadly, based on how much deviation do temperature have from normal temperatures. But individual areas, as far as impact on lives and health is concerned, may have slightly different thresholds. So all of those who would go ahead and take this job of identifying your own threshold would be able to know more about your districts. And if you are not, then meanwhile you can depend upon the IMD forecast and make use of them at a blanket level. He mentioned about how Ahmedabad went about doing IEC and awareness campaign and capacity building and using adaptive procedures, which is a part of the health sector adaptation plan as well, which we have been requesting all the districts joining today and the others to make. So it's high time that we firm up these action plans, because as you could see, there are so many states in India which have being impacted because of increased heat values in the country. And it's a global phenomenon now. We can see how even California it was impacted by these heat waves. And how these, he explained through a slide as how a preparation of these heat action plan could clearly show us a difference in pre-HAP times and post-HAP times in regards to the change of excess deaths, and shared with us a snapshot of so many documents that are available of his work. which can be accessed at NRDC website, nrdc.org, and also maybe some of them are available with the NDMA website and should be accessed there. Going back to what Dr. Nikhil made his presentation on his work, some of the important areas I think I was able to identify for my officers is first, the difference that they identify that between core temperature and axial temperature, which is important for you to make that awareness so that your pre-hospital workers and people addressing to these patients do understand the relationship. This is a very small difference, which from the study, there was hardly 1 degree Celsius difference between non-cases and cases. And so that's a very small value, and you have to be very careful for properly accounting the temperature of the patient to understand the risk to the patient. Also, an important part, I think, that was mentioned in both the presentation is about how heat is not only the temperature values, but how inclusive of humidity levels or converting it into so-called heat index by including both the variables tends to make the actual values of temperature go higher. So that's another important point to put in notice is that you don't just depend upon what are the temperature values. It is unfortunately that we cannot afford to have such loggers all over the place. But this message that is being provided to you is that be aware that there is definitely a value of 6 to 7 degrees Celsius difference between what you get as a station reading versus what actually might be a local value if you ever had the opportunity of using that heat logger machine. And so be aware that you are alert all the times. These station values are far less than what exactly may be an on-scene value, and be prepared to at least clinically well evaluate your patient when the baseline values at your from your station have gone up. And another thing that I could recognize from this presentation is about the spatial differences. So while usually in station values, many a time there's an aggregate value for the entire city that we are able to access easily, but it is maybe a possibility that different parts of the cities which may be more dense or have like an island effect would get locked up and have higher temperature values. So you should be aware of which part of your cities are likely to have higher temperature than what is the average values provided by the station. Another finding in this presentation was about the station visibility. I think it's related to air pollution probably as contributing to leading to higher heat index values because of additional contributions by pollutants. And then an important fact that you have to evaluate for whether there was an internal factor such as an exertion just before the patient became ill, and what were the other factors in the location from where the patient was picked up, such as was there availability of air conditioning and other facilities when he was picked up. So these were some of the things that I tried to summarize for my officers once again in brief based on what we got. And let's see if there are questions. Okay, there is a question. Let me try to read it out. Okay, this is a question for Dr. Ranadive. How was the sensitivity of the case definition assessed? Please.
Sure. So we essentially came up with our own case definitions based on literature review and some exploratory analysis. But we used clinical impressions of the pre-hospital providers as the reference standard. And so we looked at just standard measures of diagnostic accuracy, sensitivity, specificity, positive and negative predictive value. We unfortunately did not have access to physician-confirmed diagnoses for these cases.
Okay. Another question we have is, what exact modifications are suggested in heat stroke and exhaustion case definition based on your findings?
I'm not sure I understand the question. Dr. Hess, do you have anything?
So I think that the questioner is asking what whether the case definitions might be improved and thereby perform better. And it's a great question, but the information we had available to us suggested that probably you would need, well, we don't know how you could better, how you could improve these case definitions. I think one hypothesis is that you could include information about the scene temperature and include that as another possible predictor, and that that additional information about exposure might increase the precision and the predictive value of the case definitions. But we haven't tested that hypothesis yet. And Nikki, do you have any other thoughts on that?
No, just that at least in like the syndromic surveillance literature, our measurements of accuracy seem to line up with those, but I don't think those studies have really looked at like scene temperature or activity history in their case definitions.
So thank you. And for my audience, I'll also add that please, what is already classically well known is that altered sensorium is a very important finding to distinguish between heat strokes and others. So please be attentive. As they showed that even GCS values of 14 and below were associated with this finding. So you may not have a very great deviation from in GCS scores, but to be very careful in assessing the sensorium values of your patient. The next question we have is, data show that the patient attended by ambulance service were from working age group and at residence. That is surprising. What type of exertion they had reported?
So, go ahead, Dr. Hess.
No, please.
Oh, my understanding is that this was, it was essentially like a bivariate, like it was something that people checked on a form, like patient exerted themselves or not. We don't have any further qualitative data on what specifically they were doing.
Yes, so we collected this. So the data was collected either from the patient, if the patient was able to provide information, or from family members who were interviewed during the encounter. And so the instructions were to indicate that there was exertion if there had been heavy work, not light housework or something like that, but heavier types of exertion that you might see with heavy labor. So a lot of that actually occurred at a work site, not at the patient's residence, but some of it was residential. But unfortunately, we don't know the specific types of work that they were doing or exertion that they had undergone.
I was also surprised to know about cases being picked up from the residents. That means probably this goes against the general understanding that people usually have, that it's only those who are working outside in the field are the ones who are going to end up with heat stroke. And that's not true. We have to be careful that people, as this study showed, a large proportion of them were at their homes when they suffered heat stroke, and we have to be careful irrespective of where the people are. There's not necessary that it's only the people working outside will be the ones who will be affected by heat stroke. And the next question we have is the study picked up most cases with acute exertional heat stroke. Does that mean that they had less classical slow onset heat stroke in Ahmedabad?
So we don't know for sure because we did not have physician confirmed diagnoses. We went off of the medic impression and then also the notes. So we put together our own case definition. If someone had an elevated temperature was altered, then we considered them possibly to have had heat stroke. And it did seem that a large proportion of those patients had a history of exertion. And that was one of the clear predictors in our regression analysis. And that is consistent with what we have seen in other hot climates where young people who don't really have many other medical problems will work during heat, probably because they need to, they need the wages, but also they probably feel like they can do so safely. And what may happen is they operate relatively close to a danger zone. And in some instances, perhaps because there's a source of heat on the work site or because they exert themselves too heavily, or they just don't have a period of rest that they then run into problems with heat stroke. But we can't say for sure. This is just a hypothesis based on what we know about the disease.
Thank you. Since there are no more questions, all I would say once again is yes, the paper was really, and the presentation today was very of great benefit for the program. It's at the right time when we are starting with the heat surveillance in the country in the month of March and go on for the next few months. It's important for the program officer to understand the importance of the impact of heat. It is not anymore a condition that is of lesser value than any other cases, especially during the months of summers. And we now recognize that a lot of excess deaths due to exacerbations of chronic conditions that happen during very hot and humid days are probably affected due to the heat conditions, and we can probably save these people if we were aware of these situations and made appropriate plans and appropriate actions which will be and which will help and force situations that these people do not end up dying. And thank you for sharing all this information and the wonderful work that you have done in this area. Since the work relates to Ahmedabad, which is an Indian city, most of our officers will have an opportunity to understand that and try to implement similar work in their own cities in the country. So with that, thanks once again. Thank you, Professor Jeremy, and thank you, Dr. Nikhil. Thank you.
Thank you very much. Thank you all.